Hi, this is Dr. Nick with the ECG Academy, and this last video on this section on axis has to do a little bit with precordial leads, and then we're going to discuss the anatomical correlations to the different leads that we see on the 12 lead. Now, when we mention inferior leads and lateral leads, I just want to make sure you guys are clear with that. So without further ado, let's talk about the chest leads, the precordial leads. This was my diagram of someone's chest with the spinal column in the back and the sternum in the front. And this is how I introduced the idea that the heart is in the chest with the left ventricle pointing more posterior and the right ventricle being more of an anterior structure. But you see, radiologists, when they read CAT scans and so forth, they actually look at the body from below. So if I were to simply flip this over, it would look a little bit more like what a radiologist sees when he reads a CAT scan. It's just a different angle looking from below. And if we put our precordial leads in here with V1 being on the right side of the sternum, V2 on the left, and so forth, until you get to your mid-axillary line, you can see it's the same idea except just upside down. Now, if I put the normal precordial progression, with V1 having perhaps a little R wave and a very deep S wave, V2 having somewhat of a larger R wave, the transition point where the R becomes bigger than the S is usually somewhere between V3 and V4. And then V5 is usually a tall R with a little S left, and then V6 is usually not much of an S at all. So this is a normal precordial progression, or sometimes we call it the R wave progression because it's really the R waves that are getting bigger and bigger as we go across the precordium. Well, just like you can have frontal axis shifts, you can also have a shift in the precordial progression. And in a simplistic way of looking at it, it's almost like the heart can be rotated in the chest. Okay, so imagine if the heart inside the chest could rotate, either because of anatomical changes or because of functional changes. If the heart is able to rotate in a clockwise direction, what will happen is that the transition point, instead of V3 or V4, may wind up being V5 or V6. So clockwise rotation of the heart inside the chest winds up giving you late transition. So clockwise rotation of the heart winds up giving you late transition. Late transition occurs when the R wave doesn't grow until V5 or V6. So you have persistent small R waves all the way out until maybe V5, and then V6, perhaps the R wave finally grows bigger than the S wave, but there's still a pretty sizable S wave in V6, and we call that late transition. Conversely, if the heart becomes rotated in the opposite direction, counterclockwise rotation winds up causing the ECG to show an early transition. So with counterclockwise rotation, you wind up with early transition. And this looks like you may have a sort of a tall R wave in V1, but then you have an R wave that's bigger than the S wave in V2. And this R wave remains large for the rest of the precordium. And so this is known as early transition or counterclockwise rotation. These are often variants of normal, but it's often seen in people with conduction system disease like left anterior and left posterior hemiblocks. So here's an example of late transition. When you look at the QRS complexes, they look fairly narrow. So interventricular conduction is normal. The QRS is isoelectric in lead 3, so that gives you an axis of plus 30. But let's examine the precordial leads. You have a little tiny R wave here, and it remains small. It's still small, but look how deep the S wave is. You have this persistent deep S wave all the way out to V5. The R wave still hasn't grown much. And then finally V6, the R wave begins to grow, but you still have this big S wave here. So the precordial transition point is at V6, and we call this late transition. We might be tempted to interpret this poor R wave progression as being evidence of an old anterior MI, but we'll talk about this in a later section. This late transition is more of an electrical phenomenon and not necessarily related to any anatomical problems. Now, with this ECG is a little bit more confusing. It's the best example I have of early transition. Now, the rhythm is sinus, but there happen to be PACs that are aberrantly conducted. You can see a deep S wave here, and in V1, there is a P wave that's hidden on the T, and there's an RSR prime, so this is basically just a PAC that conducts with a right bundle branch block. But look at the underlying QRS complexes right here. You can see that the R is not as tall as the S wave in V1, but in V2, the R wave is much taller than the S wave, and the R remains tall for the rest of the precordium. So this is an example of early transition, and it can be seen in conduction system disease, as well as some anatomical abnormalities. And these are things that we'll cover in later sections, but RVH would look different because it will generally have a deep S wave in V6, and an old posterior MI would usually have a taller R wave in V1. So the equivalent of axis deviation in the precordial leads is either late or early transition. I promised that I would talk about anatomical regions of the heart and how the different leads relate to those anatomical regions, and let's do that now. Recall that the frontal leads, we have 1 and we have AVL, are all angled in this region. If we look at the precordial leads, with the sternum in the front, we have V1, V2, all the way to V5 and V6. So V5 and V6 are looking at the side of the heart, as is AVL and V1. So the lateral leads are considered to be 1 AVL, V5, and V6. Okay, so these are lateral leads. They look at the lateral wall of the left ventricle, and you have to kind of keep those in mind when you're trying to diagnose a segmental myocardial problem like ischemia or infarction. Now we have AVF, which is pointing straight down. We have 2 and we have 3. So 2, 3, and AVF are considered the leads that are best suited to examine what's going on with the inferior wall of the heart. Lastly, if you think about the heart in the chest, V1 and V2 are often looking at the right ventricle, and V2 and V3 are often looking at the septum. So we consider these to be RV leads and septal leads. And then V3 and V4 are looking at the anterior wall of the heart. So V3 is anterior, V4 is anterior. If you see changes that involve V2 through V6, then we call it anterolateral. If it's V1 through V4, it's anteroseptal. Let's kind of review the anatomy of the heart here. This is a front view of the heart with the right ventricle over here and the left ventricle on this side. Coronary arteries include the left anterior descending, which basically runs through the interventricular groove and gives off branches to the lateral wall. These are known as diagonal branches. So when you see coronary problems with the left anterior descending, usually affects the septum, the anterior wall, the lateral wall, and the apex. On the other hand, the right coronary artery, which runs in the right AV groove and then gives rise to branches that supply the right ventricle, wraps around the heart and feeds the posterior wall and the inferior wall. So inferior left ventricular problems and right ventricular problems are usually due to right coronary artery blockages. The circumflex coronary artery comes off the left main, and that runs in the left AV groove, giving off marginal branches. These are obtuse marginal branches to the lateral wall of the left ventricle, and in some patients, it wraps around in the back of the heart and supplies the inferior wall. So inferolateral changes can sometimes be a reflection of the circumflex. Now I'm going to cover the coronary artery anatomy in much greater detail in the advanced course. But for now, just think about septal and anterior changes almost always being due to the LAD or left anterior descending coronary. Lateral changes could be either LAD or circumflex. That's 1 AVL, V5, and V6. Inferior wall changes are usually due to right coronary artery problems, although in some patients the inferior wall is supplied by the circumflex. And so inferolateral changes can sometimes be a reflection of circumflex disease. So this is just an introduction to the concept that anatomical problems involving certain coronary arteries can be reflected in certain patterns of change in the ECG, and that sometimes correct interpretation of the ECG can point to which coronary is involved. So as we continue this discussion in the intermediate course, we'll continually refer to anteroseptal leads and lateral leads and inferior leads until you get comfortable with the concept that the ECG does reflect anatomical areas of the heart. Well, that concludes my discussion of the axis and the end of this section. In the next section, we'll discuss atrial abnormalities, which are a bit easier to diagnose and less complicated than this kind of stuff. But until then, this is Dr. Nick with the ECG Academy. Thanks for watching.